Yes, okay, we can start.
Yes. Okay, sir. Good morning, everybody. Today's topic of discussion is on diagnostics and management of dry eye. Coming to the introduction, dry eye, the National Eye Institute defined dry eye as a disorder of the teophyll due to tear deficiency or excessive evaporation, which causes damage to the interpalpebral ocular surface and is associated with symptoms of ocular discomfort. Dry eye is a multifactorial disease of the tears and ocular surface that results in symptoms of discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface. It is accompanied by increased osmolarity of the tear film and inflammation of the ocular surface. Pathogenesis includes genetic predisposition, systemic autoimmune disorders, viral infections affecting lacrimal gland by various viruses like Epstein-Barr virus, cytomegalovirus, HIV virus, hepatitis C, neurotrophic keratitis, hormonal insufficiency, age-related menopause, and androgen insufficiency. Also, age-related atrophy of the lacrimal gland, insufficiency of the spread of tears, such as seen in conjunctivocalysis, post LASIK surgery, chronic contact lens induced wear patients, few systemic or topical medication use.
Hello.
Yes, sir. Then
Yeah,
final outcome of
not
dry eye
audible.
diseases includes ocular surface related and patient related. Ocular surface related, especially we see punctate epithelopathy on the cornea, erosions, filaments or mucus plugs. In patient related, patient complaints of vision blurring, rapid tear breakup time leading to increased blink rate and degradation of image. Subjective distress, which leads to ocular fatigue. uh, Dry eye workshop study in 2007 classified dry eye, which is the standard classification, which classified the dry eye into aqueous deficient dry eye and evaporative dry eye. In aqueous deficient dry eye is further classified into non-Jogren's and Jogren's. Non-Jogren's which has the primary lacrimal gland deficiency, age-related dry eye, congenital alacremia, secondary lacrimal gland deficiencies due to any gland infiltration, sarcoidosis, lymphoma, AIDS, graft versus host disease, then amyloidosis, hemochromatosis, HIV, diffuse infiltrative syndrome, systemic vitamin A deficiency, malnutrition, lacrimal gland ablation, trachoma, chemical and thermal burns, endocrine imbalance, uh, erythema multiforme, and Stevens-Jones syndrome. And a few medication, long-term medication use such as antihistamines, beta blockers, atropine, oral contraceptive pills, anxiolytics, anti-Parkinsonian agents, diuretics, etc. Topical preservative drops used in lubricants, they also cause dry eye. Then reflex hyposecretion seen in reflex sensory block and reflex motor block, neurotrophic keratitis, corneal surgery, mainly limbal, taken limbal incision, keratoplasty, post-refractive surgeries, infective conditions like herpes simplex keratitis, herpes zoster ophthalmicus, topical agents, mainly topical anesthetic drops, systemic medications, beta blockers, etc. Then chronic contact lens wear, diabetic patients, aged patients. Then coming to Sjogren's syndrome, which is further classified into primary Sjogren's syndrome, which is not associated with connective tissue disorder, and secondary Sjogren's syndrome, which is associated with connective tissue disorders such as rheumatoid arthritis, SLE, progressive systemic sclerosis, primary biliary cirrhosis, interstitial nephritis, Hashimoto thyroiditis, Wegener's granulomatosis, etc. Coming to evaporative loss, dry eye loss causes, which has intrinsic causes and extrinsic causes. Intrinsic causes factors like meibomian gland diseases, low blink rate, especially in chronic computer use users, then the lag of thalmosis seen in seventh nerve palsy or etc. Extrinsic causes of evaporative dry eye are vitamin A deficiency, development disorder of goblet cells, lacrimal acinar damage, topical drugs, preservatives, contact lenses, ocular surface diseases such as severe allergic patients. Coming to diagnostics of dry eye, there are few mandatory tests and non-mandatory tests. Mandatory tests, which are commonly practiced in OPD, are fluorescein staining, Rosebank staining, lissamine green staining, mebography, and Schirmer test. Other non-mandatory tests are lipid layer analysis, which is basically done by using interferometry, anterior meniscus height, T-bud aberrometry. Commonly practiced staining is fluorescein staining. After only
You're not audible. Hello.
hello.
Yeah, I think the connection was lost in between. Can you start
Yes,
again from the
yes,
training part before that?
yes, sir. Is the slide visible, sir? सर को visible हमको नहीं.
Not yet, not yet.
नहीं सर. इसमें कैसे होगा? इसमें इसमें कोई लिंक ओपन करके देखो. जूम ही चला गया क्या? ज्वाइन तो है ना? रिटर्न टू मीटिंग. नहीं. Okay.
Yeah, now visible.
Okay, so after staining the cornea is observed on the cobalt blue filter. Cornea is divided into 5 zones. So if the punctate staining is present on the one zone, not involving the central zone, it is classified in the mild dry eye. If the two zones are involved with partially involvement of the central zone, then it is classified in moderate dry eye. If three zones are involved with complete involvement of the central zone, that it comes in severe dry eye. And so the next is the Oxford scheme, which represents the ocular surface damage in dry eye disease. So it is represented in the flow chart, which is which uses lissamine green and rose bengal staining. So entire cornea and conjunctival staining. Based on this, the severity of the ocular surface damage is depicted. So it is graded from grade 1 to grade 5. So next, coming to the most commonly practiced test, which is Schirmer test. So Wattman filter paper is used, which is of 35 Wattman filter paper, which is placed between the lateral one third and medial two third junction of the lower palpebral conjunctiva, and patient is asked not to blink for 5 minutes. So after 5 minutes, the amount of wettability of the wetting of the filter paper is noted. Normally, it should be more than 15 mm. If it is less than 5 mm, it is considered a severe dry eye. Between 10 to 15, it is considered as mild to moderate dry eye. If it is less than 2 mm, then it is considered as very severe dry eye. And there are Shermer 1 test, Shermer 2, Shermer 3. Shermer 1 is done with the without use of anesthetic drop, and Shermer 2 is done with the help with the use of anesthetic drop. Coming to tear meniscus height, this is the height of the tear film present at the edge of the lower lid. Normally, tear meniscus height should be more than 0.25 mm. If it is less than 0.2 mm, it is considered as dry eye. Coming to tear breakup time, it is also done by using fluorescein staining under cobalt blue filter. So it is the time between the complete blink and the appearance of first dry spot. So it is a time interval between that. Normally, it should be more than 10 seconds. If it is less than 10 seconds, it is considered as dry eye. So, and there are many patterns of the tear breakup time, such as area break, spot break, random break, line break, and dimple break. Area break, this is commonly seen in severe aqueous deficient dry eye. Random break is seen in evaporative dry eye, and a dimple break is seen in decreased wettability. Next commonly practiced is mebography, which assesses the severity of the meibomian gland dysfunction, which is graded from degree 1 to degree 4. In degree 1 and 2, the meibomian gland is shortened because of lack of nutrients. In grade 3 and grade 4, wide area is involved with severe atrophied glands. So, coming to the management, the foremost objectives in caring for the patient with dry eye disease are to improve the patient's ocular comfort and quality of life, and to return the ocular surface and tear film to the normal homeostatic state, and avoidance of exacerbating factors like constant screen use or constant air conditioning, etc. Eyelid hygiene should be explained. Tear supplementation should be started. The ideal artificial lubricant should be preservative free. It should contain potassium, bicarbonate, and other electrolytes, and have a polymeric system to increase its retention time. Physical properties should include a neutral to slightly alkaline pH. Viscosity agents used in lubricants include carboxymethyl cellulase, polyvinyl alcohol, propylene glycol, and hydroxypropyl. Tear retention. Next step management is tear retention with the help of punctal occlusion. Like punctal occlusion, there is temporary occlusion and extended punctal occlusion. In temporary occlusion, materials used are collagen material, which will stay for a few days, like 7 to 15 days, and they are placed in the punctum region. And extended punctal plugs is usually done in post LASIK surgery. These plugs will stay around 2 to 3 months, and which are made of collagen material. But before punctal occlusion, lacrimal sac syringing must be done to rule out any NLD block or any blockage. And contact lenses can also be worn to to maintain the tear retention. And surgery like tarsorrhaphy can be done to especially in neurotrophic keratitis, dry eye induced due to neurotrophic keratitis, to lower down the palpebral fissure. And anti-inflammatory therapy should be started in autoimmune patients. Cyclosporin, tacrolimus are also started. These are the immunomodulatory drugs. Then corticosteroids for a shorter duration, depending upon the severity of the drug, should be started. Oral tetracyclines, especially doxycycline, we will start in posterior blepharitis patient. Then essential fatty acid, that are omega sure oral tablets are given. They are started. They are given in dry eye patient, especially in evaporative dry eye patient, because it will improve the quality of the tears, and also the tear film is maintained. The newer drug in the market is Diquafosa tetrasodium, which is a mucin secretagogue, which releases the mucin. These are especially given in evaporative dry eye patients. So, based on the dry eye workshop study, treatment recommendations are level 1, level 2, level 3, and level 4. So, in level 1, we educate the patient regarding environmental and dietary modification, elimination of systemic medications, preservative free preserved artificial tear substitutes, gels, and ointments are given. Eyelid therapy, especially hot fomentation and lid massage, is advised in meibomian gland dysfunction, so that the excessive lipid or meibum is expressed. And in level 2, if level 1 treatment is inadequate, level 2 following is to be added, such as non-preservative lubricants, anti-inflammatory agents, topical corticosteroids for short period, topical cyclosporin A, which comes in the range of dosage of 0.05%, 0.1%, and 1%. Topical or systemic omega-3 fatty acid should be started. Tetracyclines for MGD, punctal plugs is started. If level 2 is not working, then level 3 includes autologous serum eye drops, contact lens, then permanent punctal occlusion is started, given. And level 4, if level 3 is inadequate, then following, such as systemic anti-inflammatory agents, tarsorrhaphy, mucous membrane grafting, or amniotic membrane transplantation in very severe dry eye, can be tried. And there are
In
other.
omega 3, you have written topical omega 3. Is anything available? Topical omega 3?
No, sir.
It was written by mistake.
Yeah, by mistake.
Oh,
So other newer diagnostics are LipiFlow, IPL therapy, then LipiView, etc. LipiFlow, uh, the image got reversed. In LipiFlow,
yeah, okay. Go ahead. This is a IPL therapy image, I think.
yeah, this is the IPL
Okay,
therapy
fine.
where
Speak
intense
about
pulse.
IPL therapy first. Yeah.
So, it is the intense pulse light therapy. This is most commonly done in evaporative dry eye, so that it gives infrared pulse shots, so that the in the upper lid and lower lid, so that the libum or mebum or excessive lipid is expressed out. This is done in 2 or 3 settings, with 2 to 3 weeks gap in between, and patient feels symptomatically better after 1 or 2 settings. And along with the IPL therapy, we also provide the patient with topical lubricants and oral omega sure essential fatty acids also.
The mask shown here is not IPL. It
Okay.
is LLLT, that is low level light therapy. So that is the eye mask.
Okay.
And the equipment besides that, you can see that handle. That is basically the IPL therapy handle. So it
Yes.
gives you intense pulses of light.
Yes, sir.
Okay,
Okay.
go ahead.
And LipiFlow also, it is also commonly practiced. It gives heat and or thermal energy, so that the same principle is same as of IPL therapy. The excess lipid is washed out, released out. And few studies also said that after a single sitting of LipiFlow, a patient feels symptomatically very better, and that can be repeat second setting can be repeated after 3 months or 6 months. And Dry eye questionnaire, commonly given questionnaires are OSDI or speed questionnaire. There are many questionnaires. Generally, we give these questionnaires to the patients because to see the severity of the dry eye, and also to see the outcome or prognosis after the treatment. So most commonly given standard dry eye questionnaire is OSDI test, which says that normal OSDI, if it is up to 13, if it is between 13 to 22, it says mild to moderate dry eye. Between 23 and 48 score, it is considered as moderate to severe dry eye. This is the another questionnaire called speed questionnaire. So take home message is that whenever the patient comes to the OPD, we have to first confirm the dry eye symptoms. After that, we have to analyze the risk factor, then give the patient questionnaire and screen the patient. Then tear film homeostasis markers such as T-Bert, ocular surface staining, osmolarity, etc. should be done, and then classify the patient into aqueous dry eye or evaporative dry eye. And after that, the stepwise treatment should be taken. Thank you, sir.
Can you share the symptom score? Yeah, can you elaborate on this?
Yes, sir. Sir, this is the speed questionnaire. The type of symptoms the patient experience, based on the type of symptoms, the various scores are given, like frequency of your symptoms: dryness, grittiness, scratchiness, 1, 2, 3. Oh, it's like that. If the patient is having sometimes, then the score is 1. If the patient is having symptoms oftenly, then it is given score 2. If he is having constant symptoms, it is considered as third score.
Okay, and how do you count total? Is there any total which will tell you it is like mild, moderate, severe?
Yes, sir. Yes, sir. This is the OSDI test. This is a standard questionnaire. We also follow the same questionnaire here. So, normal patient without dry eye, the score is 13. Uh, in mild to moderate dry eye, the score is between 13 and 22.
Okay,
If the score is between 23 and 48, then it is considered as moderate to severe dry eye, sir. This is the standard OSDI questionnaire, which is
okay,
routinely followed everywhere.
okay, fine. This thing, Aishwarya,
Yes, sir.
is there any validated questionnaire in Marathi or Kannada of this test?
Um,
So, I think this month or 2 months, what you can do is that you can create a Marathi and a Kannada questionnaire.
okay, sir.
Same thing translated to Marathi and Kannada. Okay.
Yes, sir. Yes, sir.
And those patient who knows both English as well as Marathi or English and Kannada,
Yes.
you can get these questionnaires filled by them.
Yes, sir.
Okay. And then we can compare the scores between Marathi and English, because English, this test is already validated.
Yes, sir. Yes.
correct? And then you can also publish this. And then in future, we can use the Marathi or Kannada questionnaire rather than using a
Okay.
English questionnaire, because not everyone is comfortable with English.
Yes, sir. Yes, sir.
Okay. So you
Yes.
can take this up as a project.
Yes,
We
sir.
can publish that validation.
Okay, sir.
Okay.
Okay, sir.
Uh, and one more thing, I want you to make a good video on how to do proper warm compression of leads,
Okay, sir.
because many times we describe that to the patient, but patient does it in his or her own ways.
Yes,
So
sir.
how to do it perfectly? You can collect the resources. I think there will be YouTube videos also, or there will be descriptions on these where dry management is described in detail,
Yes, sir.
and
I will
create
do
a
it, sir.
video. Okay.
Yes, sir.
Any role of secretogog? You wrote about this thing, muco, I think,
Yes, sir.
muco,
I've
this
wrote.
thing.
Yeah, this is present in Japan, but I don't think so. This is available in India yet, sir.
In between, there was another drug called ribapamide, which was
Okay.
ribapamide or something like. So it was introduced as a secretagogue. It is similar to pilocarpine basically,
Okay, sir. Okay, sir.
and cholinergic. So it will cause increased tear secretion, but I think it was not very popular.
Okay, sir.
So that was there. Even oral pilocarpine has been described,
Yes, sir.
but of course they have other cholinergic side effects.
Okay. Okay, sir.
Any surgical management of severe dry eye apart from tarsorrhaphy, AMG?
Mucous membrane grafting.
Yeah, apart from that, MMG, AMG,
AMG also.
tarsorrhaphy,
Tarso.
and also there is a this thing transplantation of salivary gland has been described. Uh,
Yes.
so I'm not sure of the results. You can search those,
Okay, sir.
and of course, for very severe dry eye with corneal scarring, we can do
Mm.
keratoprosthesis.
Yes, sir. Yes.
Okay.
Okay.
Okay. So, any questions?
Sir, I had a doubt. Hello? Hello?
Yes.
Hello?
Yes. Yes.
Sir, regarding the selection of type of lubricants, how do you go about it? Like which molecule for which condition? Like hyaluronate for which, CMC for which, HPMC
Aishwarya.
for which?
Yes,
Aishwarya.
sir. Yes, sir. There are various types of viscosity agents used in lubricating drops. So there are CMC, which cellulose derivatives, and polyol alcohol uh, patients. There. So whenever we give this hyaluronate, we also add cellulose derivative.
Any specific indication of hyaluronate? In cellulose derivatives, any difference in say 0.5% PMC and 1%?
Retention time is more
Yeah. So
in.
retention time is more if you give more concentrated drop.
Yes.
So if you give 2% or 1% HPMC, it will
Uh,
be even viscous. So it will
yes.
have more retention time, but at the same time, it may cause little blurring also. But according to severity, you can prescribe.
Yes. And
Hyaluronate
also.
is hyaluronate is considered as having some healing properties also.
Yes.
So and also it comes with tree halos.
Yes.
So it also has some anti-inflammatory properties. So probably useful in the long run. For
Yes.
mild dry eye, generally we give cellulose derivatives, which are less expensive and can be used for a long time. And then as the severity increases, we can mix it with the hyaluronate.
Yes, sir. And also there are higher molecular weight viscoelastics and lower molecular weight higher molecular weight causes increased retention time. So, and they are used in gel form, but the demerit is that it will cause a little blurring of the vision and also matting of the eyelashes. Hello.
Yes, okay. Any other question?
No, sir.
Any supplements for the lipid layer deficiency? Any drops are there?
No.
Okay, maybe you can study the lubricating drops, and some of you can present on lubricating drops itself, like what are the indication for each and every drop. Okay.
Okay, sir.
Okay. Okay. Thank you. Any
Thank you,
other
sir.
questions? Otherwise, we'll stop the.
No questions, sir.
Okay. Thank you. Thank you.